Hello everyone, this is Meldita and I'm back. So this is the continuation of the English version of reperfusion or reperfusion injury after PCI or stent insertion. Okay, post-PCI reperfusion arrhythmias. These arrhythmias actually come from the reperfused heart muscle after we open the coronary artery with the stent, and the heart muscle supported by this open coronary artery will be saved and back to its regular aerobic, metabolism. Okay, so when we have a successful reperfusion, heart reperfusion, the heart muscle will be resuming its usual activities, aerobic metabolism, and then we will be resuming our, we're gonna be resuming our ATP production. We're gonna be resuming our sodium K pump and carriers, and there will be ionic exchanges and more. So lots of chemicals and production. Some are activated. And all of these things happening will influence our cells' electrophysiology function. Okay, so I have here 3 rhythm strips. So the first rhythm strip here, okay, we have a sinus rhythm. You have a sinus rhythm in here, and then you see that there are 3 ventricular beats in here. Okay, and this is also sometimes called salvo. When you speak of salvo, that is actually consisting of 3 to 5 beats, ventricular beats in here. Or if you're comfortable, you just say short run of VTAC. Okay, and the second strip in here, as you see, we have a little bit of escape rhythm here, followed by a PVC. Okay, and then we have again the sinus beat in there. Okay, that is a sinus beat, and then we have here ventricular couplets, and then here sinus beats again, and short run of VTAC or salvo. Okay. The third rhythm strip, we have a short run VTAC here, 3 beats, because that is 136 beats per minute, followed by, AIVR or slow VTAC. The beat here is 107 beats per minute. And we have here a fusion beat that is 2 impulses stimulating the ventricle coming from above. It could be from the sinus node, it could be from the atria or junction, and 1 from below coming from the ventricle. So 2 impulses stimulating the ventricle will end up having a fusion beat, and then followed by a little bit long run of accelerated idioventricular rhythm, and that is like 93 beats per minute. Okay, so reperfusion arrhythmia. What is the most common reperfusion arrhythmia, in STEMI after PCI insertion, and it is successful or successful reperfusion? We have here AIVR. So AIVR stands for accelerated idioventricular rhythm, and it is the most common. And then it is caused by an enhanced automaticity. It is caused by enhanced automaticity, not re-entry. It is also called slow VTAC. The rate is 40 to 110 beats per minute. And the origin so far, it's coming from the bundle of His to Purkinje, or from the left ventricle to the right ventricle. Okay, so it is benign and it is harmless, and we don't treat this one. So there's no treatment, okay? And AIVR occurs during escape beats. Actually, they occurs after the escape beat, I should say, or escape rhythm. And then it also occurs, in less than 3 hours. So as I said, there's no treatment for AIVR. And in the event that somebody treated this AIVR, there's a chance that it might end up into a systole. So we don't want that thing to happen. Okay, what are the management, what are the management here to be observed to achieve reperfusion? Okay, here, there are groups here to help out in achieving our reperfusion. So what will RNs do? For the RNs, before the patient will go to the cath lab for an angiogram first, there are, things that they will do. So they start loading oral antiplatelet medication. If the ALS group or the advanced life support group of 911 failed to give chewable aspirin in the field, then they will tell the RNs who received the patient, and then we'll be the one to initiate that one based on the doctor's order. So loading oral antiplatelet medication. So we're gonna start with aspirin chewable 320 milligrams based on the order of the doctor. So these are all doctor's order, okay? So aspirin chewable 320 milligrams. We have also Plavix if that is the choice of the doctor. And that will be 300 or 600 milligram loading dose PO. And we have also Brilinta or Ticagrelor. So the Plavix is, the other name for that is clopidogrel. And the Brilinta or Ticagrelor, the loading dose will be 180 milligrams if this is the choice of the cardiologist. Okay. And that is to be given all oral. Okay. So the patient came out from the cath lab, it was found out the patient has a blocked coronary artery and a stent was inserted, and now the patient is ready to go to CCU. So in CCU, the RNs will monitor for episode of chest pain. If there's chest pain episode, we do stat ECG just to be sure that there's no blocking of the stent. If we have an ST elevation, that means the stent is clogging up and that the patient needs to go back to the cath lab. Okay, if not, then it's just probably from stretch pain. If it is good, we don't have to worry, but we will give the patient PRN, narcotic, analgesic, IV. Okay, and our continuous cardiac monitoring is always, the RNs are always vigilant, okay, for any changes or anything. And this is a fresh STEMI. We do also 12-lead ECG after less than an hour. Okay, usually in less than an hour, we do an ECG 12 leads here. And we will notice that the ST elevation starts to coming down until isoelectric. The isoelectric probably will happen in less than 12 hours. Troponin washout, as the heart muscle is, damaged during the infarction, and we revive the flow or restore the blood flow there, or reperfusion. So we're going to see troponin washout. So troponins are actually protein and enzymes, and they will be, as the cells are damaged, this troponin and the cell wall are damaged, so this troponin will be released. They will be actually released and going into the interstitial area, and then the lymphatic vessels will clear them out and bring them to the right side of the heart, to the right atrium, and going to the circulation. So normally they are actually already high in numbers. And then also we have reperfusion arrhythmias, which I just discussed, and then maintenance dose of antiplatelet medications. So the aspirin, 81 milligram, will be lifetime. And then if the doctor chose Plavix, then that will be 75 milligram once a day. Or if he chose Brilinta, then that will be 90 milligrams twice a day, all PO. And then the Plavix or Brilinta will be given. Actually, it's definite. There is actually a short period of time to be taken. So that is a definite period. So like 6 weeks, it could be 3 months, 3 weeks, and then to 1 year. So the cardiologist will make that order. Okay. Then how about interventionalists? So this is the part of the RNs, what they're gonna do in managing to achieve reperfusion. And how about our interventionalist? Okay, so when the patient is already in the cath lab and found out that there are clots in the coronaries, so the interventionalist will clean up the coronaries. They have to, there is a clot aspirating catheter that will be inserted by the interventionalist and collect these clots. If there is a heavy calcified lesions there inside, then actually the doctor will do rotablation. So rotablation is actually these particles, these plaques will be, in very fine, they will be into refined form, and they're safe, and they will be out in the circulation. Okay, and then there is also the use of IVUS. So the IVUS is an intravascular ultrasound which looks inside the coronary arteries and assessing the plaque, or even the stent deployment. But some interventionalists use it, some don't. Okay, and the bottom line there is we have a reflow of TIMI3, and that is the aim of our interventionalist, so the job is done. But sometimes if there's no reflow and the TIMI flow is less than 3, the interventionalist will inject intracoronary vasodilator, and usually commonly we use nipride or nitroprusside until the interventionalist will achieve a TIMI3 flow, and that is a success. Okay, so that's about it, and thank you.